I did my fellowship in geriatrics, internal medicine geriatrics at the Cleveland Clinic, and during my fellowship, I read Dale Bredesen's paper, and was already sort of sold on lifestyle medicine and some of the functional medicine stuff because of results we had seen that were uncommon in our own family and in my own life. When I started going through real serious memory problems, and thought I wasn't going to be able to finish medical school when I was in my early mid 30s. And so, that was sort of the beginning of the foray. So again, this is a giant experiment. And I think for most of you, the biggest thing I could say, this is obviously from partly from an international working group, and this is, often cited as, think about it as how brain deterioration works over time. Alzheimer's disease, I'm not going to get into nomenclature, Parkinson's, FTD, vascular, all the different kinds of dementias there are. But basically what I mean to say here is that over time, as we all know, like there's degeneration, right? There's degeneration, and it can be mild, and once, by definition, once someone is, as you guys all know, can no longer live independently, they get diagnosed with a dementia, right? So it's a brain or thinking problem, and then an inability to live on one's own. I think universally what we've seen, and it seems like just in recent years, also since about, just before I started my career, the field started looking more seriously upstream. How can we do things early, and how much and how early? And so far, from a medication standpoint, we have the best results the earlier we work with people. And we just had a very small pilot we did in one of the assisted living facilities. So like, I don't know if it's the same all around the world, but this is, this is a dedicated memory care facility for people that have dementia, can't live on their own. And just by doing 2 hours of sort of reablement stuff, restoration program, we had some surprising results in terms of improvements. People picking out outfits that made more sense, using phone, more talkative, making more sense in their speech, even though we weren't training those domains per se. So we are seeing even some kind of results, although not transformational, but definitely quality of life improving, and sort of decreasing the overall need for care, even in people that are sort of in moderate stages of Alzheimer's and other dementias. Just a story about this too, that I'll share with you. And again, I could be like sort of preaching to the choir here a little bit, but I got contacted a few months ago by a family friend who's in his late 60s. He's a physician and an epidemiologist, and his wife's a PhD occupational therapist that has interest in dementia. And so we've been tracking some of the Bredesen literature and functional medicine stuff for a few years now. And she develops evidence-based guidelines for a large occupational therapy organization in the United States. And so she helps me kind of, she helps me with my BS detector. Like there's just so much hype and craziness out there, and we really try to, okay, what's real and what's working, what's not. And her husband though got COVID in March of 2020, right before it really broke in the United States. And he's in his late 60s, and his father had Parkinson's. And this was before we had, any of the association data with Parkinson's, and to some degree we've seen Alzheimer's. And he was nervous because he got really bad, sort of call it brain fog, really, really confused. He was obviously very smart guy, his son, PhD, did his postdoc at Harvard, another son who's a research physician. And he was, but like all of us probably here, he was very, very scared, and thinking about the worst and imagining the worst, and as was his wife. And he, I didn't know all this. I spoke to him over a year later and found all out this later. He ended up, he just couldn't get past the brain fog. And in summer, because a lot of stuff was shut down in the United States, and really anything that was non-essential, in March, April, going into May, and then he went to a neurologist at a famous institution that most of you have probably heard of in the United States, to a neurologist with special training in Parkinson's disease, movement disorder specialist. And said, basically his question is, am I developing Parkinson's? And at the end of this, so he had the brain fog, but he also had he developed sort of a Parkinsonian gait, like a mild Parkinsonian walk, like a hitch in his step. And right, so he was really nervous, and the neurologist said, well, I can't really say you have some Parkinsonism, but I can't tell if you have real Parkinson's disease. Come back in 6 to 12 months, and I'll tell you if you have it. And he said, well, is there anything I can do? He said, well, no. He said, what about like nutrition and eating? He said, nah. Kind of shrugged. He told me, kind of shrugged his shoulders. Nah. He said, maybe do some physical therapy that could help, and ride a bike. Okay. So, he's a smart guy. And within an hour on Google, he had dozens of articles on Parkinson's and nutrition, right? He started working with that and started feeling a little bit better. He also started at the time he likes chess, and so he started doing some chess challenges and some chess strategy games online, and started noticing a little bit of his brain fog clearing. And him and his wife are sort of semi-retired at this point. They do some consulting work. And then he started thinking, okay, maybe there's some labs I should do. He went to sort of wondering why the neurologist didn't even do the usual battery of labs. And to be fair, this was the first summer of 2020 of COVID, so things were different then. And I just want to be fair to the neurologist because I know him, and he's a great doctor, very competent Parkinson's specialist, very, very knowledgeable. Knows more about Parkinson's certainly than I do. And so then our friend ended up asking his primary doctor, his GP, to get just to check some blood test levels, and he found that he had sort of a true B12 deficiency. So in the United States, most of the cutoffs are, let's say, around 200, 250. His was like 170, 190, and he was worried that maybe B12 deficiency had gone on so long that he had sort of irreversible neurologic impairment that can go along with low B12. And so he started taking some pills and felt a little bit better from it, like energy-wise, and feeling a little bit freer with movement. And then he read maybe you can do injectable B12, which I've seen improve some people, but not everybody. I just saw somebody again this week, a woman with Alzheimer's. Early, she's trying to live on her own, but really having a hard time. And so it improved a little bit, and so continue with the injections, a little bit better, a little more energy, a little bit more sort of brain energy, if you will. Still struggling a little bit with the gait, getting a little bit better, but other symptoms. And so that led him to say, oh, he's looking at sleep. He has sleep apnea that's not really treated. And so I sent him to a sleep doctor, and I just talked to him last week, and she gave some great recommendations to him, things he hadn't thought about. So, people are piecing this, just like you guys are sort of piecing this together, because what the alternative was that he just wait until he crosses the red line and say, oh yeah, you have Parkinson's. Now here's a couple medications that are really not game changers. And he just had to take matters into his own hands. So this is as you guys know, this is the kind of the reality of things right now. So I think, again, just jump in the early, really one of the key features is go early, right? Because the standard of care is just not, at least for this group here, is really not tenable. I do think it's always worth to talk about basic evaluations. I always would rather people see a neurologist, preferably someone with a little bit of extra expertise in diagnosis. I think you know what you're going to kind of get. It's either a medication and maybe some lifestyle, like lifestyle recommendations, exercise, physical therapy, speech therapy, maybe, test some basic battery of labs. Definitely, I'm a big fan of neuropsychological testing. The more I work with a good neuropsychologist report where we're testing different domains of cognition, even though the tests, as we all know, are sort of limited, and the way that they're scored is really just to pick up people that are very, very sick. I'm looking at the subtle things, because the more we kind of get a picture of, brain networks, which we may talk about this evening or this morning, wherever you may be, the more we're sort of able to kind of push the brain in the right direction, and with the limited time and resources people have, you can get a little bit better idea of ways to direct them, whether they be with exercise programs, cognitive training, or whatnot. So I continue to sort of evolve my knowledge of, looking very specifically at different cognitive tasks and functions, and try to marry that to what we know from sort of this functional medicine approach, in addition to some of the technologies that we're starting to work with that kind of push the brain or allow the brain to adapt. And again, nothing's perfect. We're not having perfect results, but we are seeing we're seeing quite a bit of stabilization when people do the work, especially earlier on they are. And then we see people that really are rolling up their sleeves are seeing improvements, not across the board, but definitely we have improvements. And then, I always like to get an MRI if we can, if it's available. I know it's not it's readily available all around the world, and it's not always available in the United States. And then, if possible, if someone can get an amyloid scan or a lumbar puncture, and that we can debate the relative merits and demerits or problems with some of the other classic diagnostic tools. But I do think that there's a role for a good diagnosis from a qualified clinician. So that's just kind of the basics. I do think if you're not aware, you guys are probably aware, this is somebody who's become sort of a friend of mine, Richard Isaacson. He's at Cornell now. This is when I visited his office. We were sort of hanging out in New York City right before, it was November, right before COVID. And the reason this was significant is because the next month, you can see that article there, Richard went to medical school. His brother is a Parkinson's neurologist. Richard's a neurologist. He did his residency at Harvard. And if that impresses you, he did his residency at Harvard. And then he had this idea of Alzheimer's prevention, right? I interviewed him, just like Chrissy, I interviewed Richard on our podcast, Evolving Past Alzheimer's. And it was like, it's refreshing to talk to him because he's really an academic that a few years ago, I mean, he was trying to get journal articles submitted in Alzheimer's Association journal, like Alzheimer's Dementia, and he was getting rejected. He was being laughed at sort of the parties, at the conferences about prevention. Everybody knows there's nothing you can do about Alzheimer's, that sort of thing. You can say the same thing in Parkinson's and FTD. You just sort of go all the way through all the sort of classic dementias, vascular. And so this was really a watershed moment. I give Richard a lot of credit, and Dale Bredesen to a certain degree, so at this point maybe from the outside, and Richard sort of from the inside, trying to change, at least in the United States and to some degree Central America, the conversation about risk reduction and prevention. So there's some real work going on, and the reason this was significant is because I think the story started to change when Richard got his first article published in 2018. To me, that's when, at least in the United States, we really started to talk about dementia and Alzheimer's prevention in a serious way, and we're going to be taken seriously. From the other side, Dale Bredesen, when I was at the Cleveland Clinic, we submitted two cases to this reversible cognitive decline paper that included 100 people. Now, always the issue was it seemed to have some kind of improvement, and this was really more specific to Alzheimer's. This is sort of a wide group in terms of dementia, and obviously one is not necessarily like the other. But the question was, okay, there are 100 people, out of how many, right? Like, out of how many? That was always the question. And because I submitted 2, but in many cases we didn't submit of people that didn't improve or didn't have the kinds of improvement we wanted to feature, right? That weren't worthy of feature. So I myself have always had doubts about, okay, well, how much does this really work? But they did, a couple of other colleagues that are in our study group, Kat Toops and Anne Hathaway and Deb Gordon, worked with Dale, and they really, and I'm sure you heard, those of you that were on the conversation with Dr. Bredesen, that they did had a prospective IRB, so they did it right, except that didn't have a control group, but at least it was a pilot study to say, okay, we're going to say what we're going to do, we're going to measure some things, and we're going to do it. And even COVID notwithstanding, they were able to see 21 out of the 25 people, so 84% of people have some kind of measurable improvement. Not just that they felt, but you could see with objective testing and asking care partners and stuff. And so that was exciting. That was an exciting thing. And we were talking about, I was talking to Dale just on Sunday about the next trial. They want to have more centers. So all kinds of questions, and it gets harder and harder. But so there are things moving. And again, you guys are. I mean, how many people before Dr. Bredesen spoke? I'm just curious, even by show of hands, like how many people were kind of tracking with this Bredesen work before, so far? if there's like, if you hover on the bottom of your screen or whatever, if you just wave at me or, hey Chuck, there'll be, it's very experimental. And then, but we're seeing that the people that give effort, it's kind of remarkable when you can stabilize. It's just not supposed to happen, and it happens consistently enough that I believe that if we get it right, and we can get it right. So, obviously everybody here has heard of aducanumab or Aduhelm. That was controversially sort of approved, sort of accelerated approval by the FDA in the United States. I don't want to go into the details of that. I am optimistic that we will have good medicines at some point, but I don't know if this doesn't seem to be a game changer. I interviewed on the podcast Marwan Sabah, who's at the clinic and really an outspoken pro aducanumab guy, and he made a good case. And I'm actually curious to know if anybody on this call tried aducanumab, because I'm curious to know what in combination with the other stuff, if we can get a better result. In other words, what as you guys know, what Bredesen argues is we have to ask if aducanumab or Aduhelm is removing toxic amyloid plaques. From a functional medicine or root cause medicine perspective, we say, well, why are the plaques showing up to begin with, right? And there's so many reasons, right? There might be so many reasons. And if you read The End of Alzheimer's, and then probably, Dale will be the first one to tell you, Dale Bredesen, who wrote the book, and was a New York Times, Amazon, Wall Street Journal, United States, at least, bestseller. We probably want to put a question mark at the end of that, right? That it sort of confused a lot of people, and that was a very controversial move. But like, somebody had to get out there and just start banging the drum that maybe this is possible. So they're doing it from the inside with people like Isaacson, from the outside. At this point, even though Dale was, a long-standing insider and wouldn't tell you that he did 2 of his postdocs in the labs with Nobel Prize winners. I mean, he's a brilliant, and very good-hearted person. And it's made a lot of original contributions to the field before the end of Alzheimer's. So he was just saying, hey, this is what we see in the test tube. Let's take it out. And so if you just look at the number of things that may give rise to amyloid, and we're going to talk about other reasons for tau plaques, and as you probably know, a lot of if you look under a microscope at the brain, if someone has a number of different dementias, you're going to see overlapping toxic proteins. And then there's the questions: can we get to an answer or some level of clarity as to why this might be happening? And there are so many reasons, and that's really the hardest thing, is getting insurance companies to pay for this. And I had to leave the Cleveland Clinic to be able to do the work we're doing now at Kemper Cognitive Wellness to sort of extend treatment options and exploration, because was really pretty limiting, even at a great place like the Cleveland Clinic Center for Functional Medicine. So I love the term Dementogens because it gives people something to think about, right? It gives you sort of a list to think about. And you can get really organized about this or less organized about this. And I think here are the things that are not controversial, right? These are non-controversial. Nobody's going to argue, although we used to. Right? Again, one of the contributions that Isaacson's made and some other folks have made, food matters, right? Cardiovascular risk matters. What we put in our body, our blood sugar, how we move matters. And I think we're learning more the more good data we have. And this is one thing. And the next slide, I actually want to do some note comparisons and hear from you guys. The kind of exercise, and I meet a lot of people that say, well, I exercise already. Well, okay, what do you do? Well, I go, I walk every day. Okay, well, that's great. That's definitely better than nothing. It's infinitely better than nothing. But when we're talking about a boulder coming down the hill, like Alzheimer's or Parkinson's, or walking half a mile a day is probably not going to move the needle. Or walking 3 times a week, right? Our experience is that it may keep people more limber, more flexible, and definitely in a better mood, which is also important, as you guys know. But in terms of the benefits, sort of the chemical and neurochemical benefits we're trying to get or sustain with when we're fighting against something like this, is that it's woefully inadequate. So what kind, for how long? Those are sort of open questions. Stress and trauma has become like this huge piece. There's much more awareness over the last 7, 8, 10 years. And then, even since 2020, now it's, it was a buzzword before, now it's, it's everywhere. And then when you look for it, you start to find it more and more. PTSD, I think last year, was somebody will probably know, summer of last year, there was another article saying now PTSD, post-traumatic stress disorder, so traumas that are unresolved and untreated, actually increase the risk or likelihood. So they're highly associated with developing Alzheimer's and other dementias, right? So these are real things. And I think at least the next level of understanding is to come with the connectome, understanding brain connectomics, which if we have time, I would like to talk about just a bit to get your thoughts about it. Sleep has become a huge deal. I mean, I've become like maybe the most aggressive thing that I'm looking for are sleep and oxygen problems. To give you an example of what I'm talking about, most of the time what happens is I'll say, look in somebody's mouth, maybe they have a small airway. They don't have to snore. I remember meeting with the head of Cleveland Clinic Geriatrics at the time. If this is being recorded, maybe he doesn't want me to share his name, but at the time we agreed that Medicare, a major government payer in the United States for healthcare, often won't pay for cognitive impairment or mood disorders as a reason to look for sleep apnea, right? Sleep apnea being primarily a problem of low oxygen, and secondarily, or maybe just as important, not being able to click through all the stages of healing and restoring sleep, right? The easy way to say it is sleep is like a washing machine for your brain, right? And if I'll send people for a sleep study, and even when we can get them approved, we'll get a sleep study back, and maybe they'll see a sleep doctor and say, well, they just said it was a mild sleep apnea, or my primary care doctor said it's just a mild sleep apnea. And then my response is really like, we're trying to do everything we can for a super aggressive neurodegenerative disease, and you're telling me a little bit of brain damage every night is okay, right? That's essentially what we're saying with mild sleep apnea in the setting of neurodegenerative disease. And you could say that's hyperbole, that's an exaggeration, that's an overstatement. But I've seen people that have made no other changes, and all we've done is treated mild or moderate sleep apnea. I'm not talking about severe graded sleep apnea, and they've seen improvements in mood, focus, alertness, sometimes even memory. We saw, one person, my mom's just more there, just more checked in. So it can be a big deal. So we're trying to put all of these things together, and then toxins, environments, how connected we are physically and socially. I have a lot of thoughts about that as well. Again, I think when somebody will probably know, Dr. Whitehouse might know, was American Academy of Neurologists just added this year, at the end of last year, air pollution, right? People that are in zip codes with more air pollution as another risk factor for developing Alzheimer's. We've seen from the work at USC, Dr. Finch, that when you look at brains of people that have Alzheimer's and other dementias, they have more mast cells, that have expressed themselves on slides, and they seem to be associated with zip codes that are of higher air pollution. So that's not an official an official testimony. So these things are not controversial, but these are non-controversial. And so what I can tell you of so-called knowns, right, of known things, and I'm saying this, my opinion. This is my opinion based on 7 years of pretty, which is, again, I recognize that's a small amount of time. 7 years of really focused on this issue. The things that seem to work consistently for anybody that is able to give enough effort, we get some kind of result, sometimes dramatic, sometimes less dramatic, with the following, and there may be a couple of other things. And then I'm going to just pause, and maybe we can have just a little bit of a back and forth about it. So first is, like, the earlier we can jump on this, the better. And that, it sometimes makes us feel, well, I wish I would have known about this 3 years ago or 5 years ago, but we didn't know about this 3 or 5 years ago. I didn't have an opportunity to talk like this 3 or 5, like there was like, this is the world, the world, at least the English speaking world that I'm aware of, is sort of waking up to this. And then, you have to be able to get access to this, right? You have to be able to pull this off. This, as you know, is not an easy thing to pull off. If you ask people that did, in the Dr. Bredesen's trial, the 25 20. So, but people that are doing it really need, I think, you guys, I shouldn't probably be telling you this because you should probably be telling me back and telling me much more than I'm aware of, that this is like the people that I see succeeding have like a purpose. I was so moved, and so many people were moved when they heard Chrissy's podcast interview that we did with her, because they were just like, wow, this is like a model of someone who is struggling with a real thing, but is doing it differently than I thought, than I thought it would be done. We say, this is not your grandmother's dementia. It's just different, more younger people, more people that are able-bodied. It's just unbelievable. I remember the first time I saw somebody who's 49 years old that didn't have like a genetic kind of Alzheimer's. And it was like wild. And we see more and more of these. So purpose and commitment, spiritual centeredness seems to make a difference for some people. Diet, I mean, absolutely. Blood sugar control. I've seen now a few people, but not everybody, improve with sort of ketosis, mild ketosis. You don't have to go hard. I don't think ketogenic diet is really a healthy diet long term. It's very much a therapeutic diet. It's a very hard one to adhere to. But even just getting some of that flexibility back, sort of like a boot camp for your metabolism, going through a couple months of a ketogenic diet, and then sort of every once in a while dipping into a ketogenic diet. I love Bredesen's concept of the Keto Flex 12-3, which I probably talked about. You can just find that information on the internet or in his books. The idea of definitely trying not to eat too close to bedtime, trying to not eat, for about 12 hours and letting the body sort of do its work. We see that more and more in the fasting literature, and people that are in low, like fasting mimicking diets from Walter Longo's work at USC, which is, it's a sort of NIH or US government-sponsored research. It's, over $50-60 million of research has gone into that, sort of the proof that caloric restriction can really help in a lot of ways, not just one. And I just had a patient today that was improving with that as well. So yeah, so I'm also curious. I'm curious, what you guys are finding with diet, and what's practical, what's difficult. It's sometimes helpful to have people measure ketones. We've had people that have diabetes and they're very glucose sensitive, and they don't even realize how sensitive they are until they start rechecking their blood sugars. And like, they'll notice, wow, really fuzzy, foggy, and we don't know why. And then we start checking blood sugars, and like even just from like rice or noodles, somebody's blood sugar might spike. Again, by US numbers, we're talking about, let's say a normal spike, we'd love to see not more than 140 of a blood sugar. And somebody's get to 190, 210, and they're confused and their cognition. I've seen this several times now. So again, it's not everybody's the same, but I've seen it so far more in men than women. This idea where we use ketosis and ketones, and we have sort of these kind of dramatic improvements. But I'm not sure if there are women on the call that have tried a ketogenic diet, particularly with Alzheimer's, because I think frontal temporal dementia may be different. Like, we've had some adverse reactions. People got worse with a ketogenic diet. It's a small number of people, but I'm just curious. This is the first one I'd like to throw out. Alzheimer's, we've seen pretty consistently. Improving. Can anybody sort of share their comments on a ketogenic diet or dietary strategies that worked? I don't know. Chrissy was suggesting maybe we do it by hands. We're looking, like, locally, we're looking for good partners that are willing to, like dentists and neurologists and sleep doctors that understand the need to be sort of aggressive for people like us that are just, we're not just talking about sleep apnea. We're talking about like we're talking about treating a piece, like a bunch of people sort of, I think Kate also, and Chrissy mentioned, just like these, little piece here, little piece there, and just treat as many of the triggers. Bredesen likes to talk about 36 holes. I once asked him in 2016, we're up at his old stomping grounds at the Buck Institute on Aging, and I asked him, how do you know it's 36? How do you know it's not 50 or 100? He said, well, it won't be 200. It won't be 200. Maybe 100, or maybe 50. Like he said 36 is what he could see then, but he didn't think it was going to be an infinite number, right? He didn't think it was going to be an infinite number. Like Yeah, then the other thing, this may be obvious, and this may be obvious, but like, educating care partners just in terms of communication, it's amazing how much you can sort of diffuse 20, 50% of some of the difficulty in situations just with sort of an awareness of what's happening and sort of coming back to that and coming back. And everybody, we all will reach our wits end. We all, all the usual stuff we all know, but it's just another piece that seems to help. I learned this from traumatic brain injury patient soldiers in terms of like they would say, oh, I don't remember. These are like 40-year-olds. I would say like the next frontier for us that we're looking at now in the clinic, and again, this is one of the reasons I had left the Cleveland Clinic to be able to do this kind of stuff, was we're looking at, there's a variety of technologies, fMRI, near-infrared spectroscopy, NIRS, FNIRS, and then, there's good old EEG, right? EEG, we can get a signal or a beat on where things are sort of going off. And this has been pretty eye-opening so far, to be able to do these sort of, so-called brain maps. And we're finding kind of new ways to push people. Like, over time, the brain ages just like our brain, just like our joints and our skin and the rest of our body, everything ages. So there's a certain, obviously, as you guys know, we all know there's normal cognitive aging. But then there's obviously with dementias, it's accelerated, cognitive degeneration. Not everybody needs a knee replacement, but some of us do. And so, there's a variety of clinical trials going around in Europe and the United States. And I'm not as aware of what's going on in New Zealand, Australia, and in non-English speaking countries right now. That's my own bias and limitation. But the introduction of technologies that presume that the brain is responsive, meaning if we give the brain a signal, it can do something, it can respond. It is another way, transcranial direct current stimulation, transcranial alternating current stimulation are ways, we have people that come into clinic on a regular or fairly regular basis, and they get treated. Like we put device electrodes, et cetera, on them for all, so these are all things that are cleared and safe as long as people don't have a reason not to, like they have a piece of metal in their head or something like that. And we can sometimes get more blood flow. We can push energy into a brain and influence a network, right? This whole field of connectomics, right? The brain, instead of thinking, both with exercise, cognitive tasks, and some of these technologies, we feel like right now, I guess it's hard to be certain of this because you have to be doing this for years and to really be more certain. But we're following the literature. I again have interviewed and hung out and done fellowships, short week-long fellowships, and this kind of technology with some academic leaders, and then we try it in the clinic. And so we had, just in the last few weeks, we've had two women on the younger side, around the 60s, one's in late 50s, one's 60. And the brain is uncommonly slow. Like we see the speed of the brain slows down in dementia. It slows down a little bit with aging, but it slows down dramatically with almost every dementia, any kind of dementia. And you see it's very obvious on these squiggly lines in the brain, on these EEGs and these brain maps. But we can influence that. We can influence that. And I saw two ladies that had come in for fairly intensive treatment and doing really well with the speed of the brain. Actually, we sped up some of the compensatory pathways or mechanisms in their brain, and they're moving faster. And they're in addition to the other things that they're doing, have recovered some measure of function. One's on disability because she's been so incapacitated. So things like being able to try to remember that they have a bill to pay, or knowing what they paid for something, or being able to get in and out of a parking lot in their car. So not just memory or executive function, visual spatial reasoning, calculation, all those kinds of things. It's really kind of phenomenal. We're designing an environment right now because one of the hardest things, I think somebody mentioned it, Bobby maybe, some people do well with the eating part of it, but they do not as well with, the exercise part of it. A lot of people, we recommend, oh, hey, you should do something for your brain, learn a new language, I push people sometimes to get on technology. I just saw a woman who came, her and her husband live on a 600-acre farm out in the middle of the farmlands in the middle of America, 14-hour drive from us. And she didn't have internet. She didn't have a smartphone. Her and her husband, who's in his 80s, he still farms by himself, basically, 600-acre farm. And trying to get her, she didn't want to use a computer. And she doesn't want to have internet. And it's hard, as you know better than I, it's easy for me to tell someone, hey, you should get internet, and take that as a challenge. But there's just a mindset of it's not happening. I don't want to do it. I don't want to struggle with it. But what we're designing now is an environment so that we can facilitate in a fun way, like an intensive experience. So every day, both we're combining physical exercise and cognitive tasks and a bit of technology, to sort of accelerate the results and get people faster results. Australia is actually ahead a little bit in their sophistication in the so-called reenablement. This is where we are trying to give people a program to cognitively restore. This is something I've been wanting to do for about 7 years, and it's been in plans, and we did a small pilot, like I mentioned, in an assisted living facility here in Cleveland that we're affiliated with, and so in addition to that, we see more and more people piqued and triggered. There are a number of people that are more familiar with this than I am, it sounds like, on this call, but that are very, 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 very traumatized and have a lot of issues, right? A lot of issues, and from a traumatic past. In fact, we just did one of those brain maps. We saw two signals, both a signal of call it stored trauma with an eyes open EEG, sort of a hypervigilant function in some areas in the brain that slowed, that we see a trauma, and the neurodegenerative piece. So we're treating two things. So again, we're parsing, that's the first time I saw that. We're parsing this out sort of piece by piece, and then trying to give people recommendations that they can follow, which is, as you guys know, it can be hard, but also, like Chrissy's point, somewhat personalized, or as personalized as we can get. And we check all the labs. I see people talking about B12 and homocysteine and hormones, but the idea of cognitive challenging, and so we developed sort of a curriculum where we're rebuilding skills. It's sort of like cross-training for different aspects of working memory, attention, executive function, logic, reasoning, things that are really hard that people wouldn't want to do on their own. Bring them in and just say, hey, just do this with us, and we'll have some fun with it. There's a social aspect, a co-regulation aspect of it. It's just really, so we could sort of call these sort of bottom-up approaches, in addition to some exercises and some breathing, stimulate vagus nerve function. So like also settle people down a little bit. And as everybody knows, it's not something you just do once, just like physical exercise or eating right. You have to like keep it up. That's the hard part of all this stuff. But the cognitive reablement literature, which is a term I first saw in 2017 in the literature, the idea of restoring some measure of cognitive function. Everything I've read, every study I've looked at requires really sort of an intense program, because it takes a while for the brain to change. Like, it doesn't just change, although we've seen improvements of brain fog and things like that within weeks sometimes on a ketogenic diet. To change like network activity, and then certainly to change structure, takes months and probably years. So those are the things that we think we're just like really sort of excited about that. And it is it's totally exhausting. It's exhausting, and the people that I see that are sort of so-called succeeding are either doing it on their own, or they have help. So these changes, the network changes happen. They take a while. So then we get into what I would call the more experimental stuff, right? Beyond the kind of basics. And hormone replacement, we've seen really move the needle. I mean, I've seen hormone replacement, it's hard to talk about some of these things publicly, especially if it's recorded, because I don't get to hormone replacement for a lot of people. Like, if people can't get a decent diet and exercising, so they can't sort of reduce the risk of any kind of, even if it's a small chance for a side effect. Sometimes I don't like to just bust out the hormones right away. There's maybe one rare case where we've done that. But one of the cases we published in that first reversal of 100 cases was where a woman was 77 years old with ApoE4. She had neurology, and she had neuropsych and MRI, all consistent with amnestic mild cognitive impairment, or pre-Alzheimer's. And she'd done everything. She couldn't read anymore. She's a big reader, living alone. Her 2 kids lived out of the state. And she came with her daughter, who was a nurse. And after the first 3-4 months, she just wasn't having any improvement with the basics. And then we started hormones, estrogen, progesterone, etc. And she came back like 3 months later. She's like, "Oh my God, I'm less anxious. My skin has improved, and I've read 3 books, and my and so it was really that was my index case for this. And it's not something I push. We have usually a long talk about what's the relative the risks versus benefits. But again, I'm curious to know about sort of if you have questions, comments, especially people if you haven't talked yet about this idea of chronic infections, toxins. Very hard thing to measure. Sometimes I get labeled as like, I don't believe in mold, or I don't believe in Lyme's disease. It's not that I don't think that they're a problem. We don't have great ways to measure them in that are reliable and certainly that are accessible and reproducible. So these things may have an impact, but it's hard to go out and speak and say, you should do this, and this is for sure contributing to Alzheimer's. And I may differ from a number of people that are doing sort of functional medicine, or sort of Dr. Bredesen's kind of medicine, not in the sense that I don't think that they're contributing, but more in the sense that, how do we measure these effectively and reliably and reproducibly? So we definitely ask about it, and then we come up with a treatment plan. But it's hard to tell someone, oh, you need to do $40,000 of improvements on your house, or you need to move out of your house because mold is contributing to Alzheimer's if they have nowhere else to go, without really being clear on the benefits. So that, I don't know if it's accessible to you, or if you have a doctor that would look at transdermal estrogen. We did a great interview with a woman, OBGYN, who's been in practice for 40 years, named Felice Gersh. She published in an open journal, BMJ's open journal, with another mentor of mine, James O'Keefe, on the potential benefits of estrogen for vasculars, for cardiovascular. And we talk about brain health. It's Felice Gersh on our podcast, the Evolving Past Alzheimer's podcast, which is free. So it's maybe worth a listen, because that's something that we have seen the needle move. But there's, that's not something I would do on your own. That's certainly something that I would see a skilled clinician for hormone replacement. There's some things to look for. I think it can be done reasonably safe, but it's certainly not the standard of care, and have to have a long conversation about sort of risk versus benefits. That having been said, I've seen many people improve, but not everybody with hormones, because it's not a one, as you guys are all pointing to, and everybody who's sort of typing in, is not like we're trying to do as many things as we can. And so, I mean, yes, gut health is a huge deal. Some docs put, I think, more of an emphasis than I typically do. We try to do it through food, right? Probiotics, supplements, gut healing protocols. Every once in a while, I'll reach to a couple of other things. But again, we really have to start at the basics. And some people would put the gut right up front, and a lot of people would disagree with me, and close friends and colleagues of me that would say, "Oh no, we got to start with the gut." I think it's not an unreasonable thing, but like, we got to prioritize for people, because as you all know, this is a lot of work to do all this. But the more people do, the more we find they retain success, and this reablement idea is one that I'm pretty excited to move forward on, and I'm excited about the opportunity to this environment that we designed at Kemper Cognitive Wellness to run some participants through this kind of program that's what we think is adequately intense. Could always be better. We'll be refining it depending on the kind of feedback and results that we get. But it's the most excited thing I think I've had so far in terms of looking forward, other than the concept, meeting the concept of functional medicine and Bredesen's work. Thank you.